Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. EM Cases is part of SREMI, Schwartz-Reisman Emergency Medicine Institute, the nonprofit organization dedicated to improving EM care through research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Tickets for online virtual EM Cases Summit this coming February go on sale November 2nd at 10 a.m. Eastern Standard Time on the EM Cases website. We've confirmed amazing speakers, people from all over the EM landscape, Scott Weingart to Sarah Reed, Tarlan Hedayati to David Carr, David Yerling to Aaron Sayal, Michelle Clayman to Nan Swaminathan, Justin Morgenstern to Ken Milne, Burke Tillman to Sarah Fooey, Chris Hicks to Katie Lynn, and the list goes on and on. Now, if you've been benefiting from some of the free EM Cases stuff we deliver, the podcasts, the blogs, the videos, the Q&A Pearl of the Week, the Just for Nuggets, even the Quiz Vault is for free, please consider supporting EM Cases by buying a ticket to the summit so that we can continue to provide free open access medical education. No firewalls, no paywalls, just pure FOAMed. Again, register at emcases.com, November 2nd, 10 a.m. Eastern Standard Time. On to the meat of the podcast. So this is a special main episode podcast in that it features highlights from this year's CAEP conference. That's the Canadian Association of Emergency Physicians Conference in Quebec City. CAEP is Canada's equivalent of ACEP for all you US listeners out there. We already featured Brett Burstein and Gary Joubert on febrile infants from CAEP on the last main episode. In this main episode, we have a wonderful potpourri of great stuff. To start, we have one of the most intriguing and controversial interviews I think I've ever done with two giants of emergency medicine, Paul Atkinson and Grant Innes. We discuss their article, Saving EM is Less More, from CGEM this past year. If you haven't read it, I highly recommend you do so. It's short and profound. Here's the interview from CAEP 2022 in Quebec City. In our emergency medicine specialty, there's an elephant in the room. I was struck by the insights that I read in a recent CGEM article authored by our two guests on this podcast entitled, Saving Emergency Medicine is Less More. It contains descriptions of what's happening in EDs across Canada, and my guess is probably elsewhere as well, that we are probably all thinking about, but perhaps haven't quite vocalized, or at least not quite so clearly yet. Up until recently, my personal opinion on this matter is that we should be providing care to anyone who shows up to the emergency department, and we should be proud to do everything that we possibly can to take care of our patients in the best way that we can. And the more skills that we have to take care of these patients, the better. And we should be proud as emergency physicians to be able to handle anything and to take on anything. And that's been a theme that's come up in EM Cases many times before. However, considering the constraints and the pressures on our systems these days, we might have hit a threshold whereby we might want to start rethinking about what emergency medicine is and how we define it. I'd like to start off in a way I've never done before on EM Cases, and that is to simply read the first paragraph of the article. So here it is. Emergency departments are failing. Triage lineups, packed waiting rooms, ambulance offload delays, unacceptable treatment delays, waiting room disasters, and frustrated patients leaving before they can be seen. Add COVID to the mix. Long, hot days in masks and PPE. Aerosol-generating procedures on critical patients. Ventilated patients and screen-positive patients blocked in the ED waiting for non-existent ICU or isolation beds. Dangerous daily exposures for staff, susceptible patients, and their families. Nurses hitting the wall, leaving emergency departments for more sustainable lives with growing staff shortages, further depleting ED capacity. A vicious cycle of demand, dysfunction, and distress that aggravates crowding, waiting times, and left without being seen rates. Does this all sound familiar to you? Well, I'm just really impressed that our two guests today had the audacity, I guess for lack of a better word, to publish this, because this is something we really need to talk about. I think it really is, again, what a lot of emergency physicians are feeling and thinking. And the nice thing about this is that we're actually going to offer up some solutions to all these problems that we had by the end. So the first part of this might sound a little bit depressing, but I can just assure you that we're going to try and turn this into a positive thing and come up with some solutions by the end. So we've got two veterans of emergency medicine on this podcast, one from the East and one from the West of Canada. First, we've got Dr. Paul Atkinson, who I can't believe I haven't had on the podcast up until now. I was saying similar to Connie LeBlanc, who I interviewed yesterday, it's one of the major oversights of the last decade that I haven't had you on the podcast. He's the clinical academic head of EM in the Horizon Health Network St. John, the assistant dean of research, Dalhousie Medicine, New Brunswick, professor of EM at Dalhousie University, and deputy editor of the Canadian Journal of Emergency Medicine, CGEM. Welcome to EM Cases, Dr. Atkinson.
Thank you, Anton. It's great to be here.
And Dr. Innes, you probably remember from our overcrowding and access block episode. He's truly a legend in emergency medicine. I think the coolest thing is that he was actually Peter Rosen's resident way back in, where was it, Colorado?
Denver.
He was the founding editor of CGEM. How cool is that? The clinical department head for emergency medicine at Alberta Health Services in Calgary. And he's a nationally known researcher and opinion leader in emergency medicine who's published well over 100 articles. Welcome back, Dr. Innes.
Well, thanks, Anton. It's really surprising to be invited back.
And he's humble too. Incredible. All right, Dr. Atkinson, it sounds to me from the intro paragraph that I just read out from the article that EDs might need fixing. But my understanding from your article is that it might not be the EDs that need fixing, but the rest of the healthcare system that needs fixing. And we touched on this a little bit with Dr. Innes in our episode on overcrowding and access block. In that episode, we concluded that overcrowding is more a problem of what's going on upstairs in the hospital and having poor access to care outside the hospital than what we were doing in the emergency department. But before we get into that, can you just give us a bit of a background with regards to the current trends in ED utilization in Canada? Like what's going on in terms of the problem that I've been hinting about? Give us some numbers to kind of strike it home for us.
For sure. And again, thank you for the opportunity. Okay, so this is a really hot topic. And I actually, since we're circling back to background, I'd like to just go to the top of your introduction, if you don't mind, and then get to the numbers. And that is to say that I don't think either of us disagree with you in the premise that you laid out, that we are there and we must provide care in the best way possible to whoever comes to our department. There is no challenge to that belief that the patient in front of you deserves the best care that is possible to give, and we must have those skills. However, the numbers just seem to show that those patients who are coming to us and presenting in front of us on a daily basis, the numbers are going up, and they're projected to go up and to increase at a rate that's higher than population growth over the next, I believe, 20 to 30 years. And this is actually from a 2013 report, which was co-authored by leaders in many specialties across Canada. And it's really, it's a report from the Canadian Foundation for Healthcare Innovation, and it's a warning. It's a warning that this is unsustainable. We can't, without further investment, deal with this rise. Internationally, and you may detect a slight accent here, I've been in Canada now for 12 years. Previously, I was in Cambridge in the UK, and before that in Australia and Ireland. Don't ask who's chasing me around the world. But the numbers here were quite staggering when I first came to Canada and realized that the emergency department is the place to go. You need healthcare? Go to the ER. That seemed to be the mantra. And not just go, but be sent. And so the going there when you need something is the natural response to acute illness or perceived acute illness. I need help. I'm going to go where I can get it. But we've created a system whereby that seems to be the only option for many people, which is different than in other similar developed countries around the world. And I'm not being critical of our system in terms of the level of care we provide, but I think we are being somewhat critical, or at least pointing out areas for improvement in terms of access, availability, and willingness to see people in a timely manner. And so that, again, is backed up by the OECD reports, which show that it's not just for emergency care. And this, again, you've said it's not really about emergency departments failing, even though that's our opening line. That's to provoke thought. It's clearly that the system of primary care specialists, post-operative care imaging, is inaccessible at many times of the day, week, or year. So that's the background. But I don't want to challenge, I'll re-emphasize this. When I'm on shift, and I think when Grant is on shift, patient in front of you gets the care they deserve from us.
Understood. It sounds like accessibility to care is sort of the main problem here. Can you just describe for us what the access to care issues are for patients, Dr. Innes?
I like to frame it as access block. And access block is simply the inability to get necessary care within a reasonable time frame. So access block, it's the wrong care in the wrong place. So it's emergency patients on EMS stretchers in hallways who are not getting emergency care. It's sick, complex medical patients lying on stretchers in emergency departments that are not getting medical care. It's elderly ALC patients lying on inpatient units, not getting rehabilitation, and as a result, suffering cognitive decline and deconditioning so that ultimately they can no longer go home. They get institutionalized. So access block is just care in the wrong place or not getting care, and as a result, suffering adverse outcomes.
All right. And could you expand a little bit on, in particular, primary care, surgery, in terms of what the specific problems are there in terms of accessibility?
I think that, as Paul suggested, Canada is not a high performer. We've heard over many years that Canadian healthcare is second to none. In fact, Canadian healthcare is second to just about all other first world healthcare. So Canada actually performs worst of first world countries in terms of access to primary care, access to specialists, access to imaging, access to long-term care. And when people can't get the surgical care or the imaging or the specialty care they need, there's really only one door open in the system, and that's the emergency department. So as a result, Canada has the highest ED utilization in the first world. People can't get care anywhere else.
Yeah, it's interesting. You know, we just had our EMU conference at North York General a couple of months ago. And Catherine Varner, who's an emergency doc and researcher who's been on EM cases before talking about ectopic pregnancy, she did a great talk on postpartum emergencies. And she presented this graph that showed the timing of postpartum complications. And the complications after delivering a baby occur at the highest rate the first few days after delivery, makes sense. And then they slowly taper down and then are pretty much close to zero by 6 weeks. And typically the so-called standard follow-up after delivering a baby is, guess what? 6 weeks. And I imagine it's pretty similar to any major surgery that the follow-up with the surgeon is 6 weeks. And I'd like to see the data of the complications after surgery, but my guess is that it probably comes down close to zero by 6 weeks. So it seems strange that the surgeons are choosing 6 weeks as a follow-up when maybe they know or they don't know that that's actually the time when they're least likely to have complications. And of course, in those 6 weeks, where do they go? They go to the emergency department.
Yeah, I think we have possibly created by many unintended decisions through Medicare funding and just practice styles, this acceptance that the emergency medicine consultant is there for any unscheduled care, even an anticipated complication if it's inconvenient. And so I think we have to be careful because we are emergency physicians. Let's not in any way frame this argument that we do not have a skill set that is valuable to patients when they are having an emergency. That is why we exist. And so some of these complications, that's our business. That's our job, right? The unexpected severe bleed, the septic hypotensive patient with retained products, those are why we are there. So let's just be really clear and say we are not saying we will not be involved in the care of people in the setting of post-operative complications, etc. But there are predictable complications, as you've outlined, for instance, in this and in many other settings, where it is not emergent, but it is urgent or even semi-urgent. And I think that is what we're saying. There needs to be an alternative pathway for the stable patient with a complication to really get the best care. I think since we wrote this article, I think a few people have said to me, is this just complaining, Paul? Is this just you don't want to do it? I'm like, no, it's really not. When I go on a shift, I see patients. Truthfully, I may go home and there will still be patients waiting there. It impacts me emotionally sometimes, but I see the patients in front of me. I do my job. I go home. It impacts the patients. They are the ones suffering here. They are the ones who don't have access to the best care because I'm not necessarily trained in those non-emergent complications. The analogy, I think it fits in here in the conversation. People have said to me, so you're saying the Titanic is sinking and we're all on board? I'm saying, no. The Titanic is slowly sinking. We are the lifeboat in emergency medicine, and there's no room left in the lifeboat. People are now in the water. The lifeboat is full. It's our job as the emergency part of the system to pull them out of the water and get them to shore, and we can't even do that.
Fantastic analogy.
I would add to what Paul said is it's not an unwillingness to provide care. We should be trying to move towards a system where the patients get the right care in the right place. And the emergency department is not always the right place. And so a story, my mother and I actually have familial tremor. Hers was quite bad. She had a brain stimulator implanted. She said her surgeon was a wonderful guy. He was just amazing. He cared so much about her. He explained stuff. And when she was discharged from the hospital, he said, this is complex surgery. This is really important. If you have any problems at all, go immediately to the emergency department. So my mother did have a problem. She got an infected lead. She did what she was told. She went to the emergency department. She waited a few hours. She saw an emergency physician. She said the emergency physician was wonderful. He spent 15 minutes with her. He said he'd never seen one of these things before. He went and read about it. He came back. He talked to her some more. He said he didn't know what to do with it. So he phoned the surgeon, and they arranged a surgical follow-up in the office the next day. And so sending people to emergency departments when this is not the right location for the care, that just gums up the system. So the most important thing is, where is the right place to get the care? The second thing is, if you multiply that scenario by 100 every day and you have a huge number of people coming into emergency departments who are going to the wrong place, the demand on the emergency department is high, the demand on the staff is high, the stress and the burnout is exacerbated. And then when my mother told me the story, I said, that emergency physician should be fired. He spent half an hour and an emergency department stretcher on a case that shouldn't be in the emergency department. Meanwhile, there's somebody out in the hallway with a subarachnoid hemorrhage. So this is a real misallocation of care.
So we've touched on the accessibility part of this. There are many other drivers of the crazy demand that's placed on EDs these days. Could you just, Dr. Atkinson, go over some of the other factors that lead to the ridiculous demands that we have in the emergency department in 2022?
Maybe we'll start with patient complexity. I think we as a medical system, and I think we need to include right from public health, preventative medicine, primary care, everything that could be considered part of the healthcare system have done a fantastic job because now life expectancy is going up. But of course, that means people living with multiple comorbidities. It's rare these days to see somebody who isn't on some form of medication, who doesn't have some past medical history. the median age of our population that we're seeing in emergency departments and just in Canada is going up. And so that places another cognitive burden onto people who are not necessarily trained for that. I think if you were to say, well, what is core training in emergency medicine? And I know that's a whole other debate, right? That's a whole other discussion about how you train as an emergency physician. I don't really want to go there. What I want to look at is when you're trained, what's your core skill set? What's on the job application? What do you have to have when you apply to come work? You have to have your ATLS, your ACLS. You might have to have ultrasound, some airway skills, etc. Those are of little relevance to the patient who comes in, who is in a little bit of chronic heart failure, who's having some falls, who doesn't have a carer at home, and who now presents to your department on 15 different medications when there's no bed to admit them to and no service to send to them at home. And yet that is not just an increasing part of our job. I would say that is almost becoming the job. So if I was going into emergency medicine today, I would have to ask myself, what is the skill set that I need? And when I do that, and when I write it down, and I've done this, I've said, what skill set do I personally in my own professional development now need to look to improve? When I look at it, it doesn't look like emergency medicine. So this was another reason to really think this through. Am I the right person to be dealing with this, or are they in the wrong place? All right. So that's one thing. And then not just that, the unmanaged chronic disease. So those are the people who maybe have medications, who have a diagnosis, who've had a test, who've decompensated post-surgery, something like that. But we are proud of our universal healthcare here. And I'm proud of what we call universal healthcare. I would love it to be universal. I think we're failing a large part of our population, and I think it's very political. I'm not sure if it's designed to be cost saving. I'm really not sure. It's very complex, but 10% of the population not having access to primary care does unfortunately lead them to the place where they can get that care. And again, while some of us may have that training on the way through, for many, it's many years ago, the primary care training, and for many people, they never had it. Add to that now the most recent straw that is breaking the camel's back, to use that old analogy, staff shortages. So the burnout is real. And of course, it's a self-fulfilling prophecy or a cyclical event here where there's less folks at work, there's more stress, we try to cope with increasing numbers, we burn out more, and we spiral downwards. And listen, we're at CAEP here. We're at CAEP 22, and it's been rejuvenating for many of us just to touch base. We haven't seen each other for a long time. And, I have a lot of friends that I've made over the years here in Canada. And while it's wonderful to see everyone has this story of, well, how are you? Well, and there's a pause. It's not great. It's not wonderful. It's not, here's where our program's going. It's, well, yeah, that's the response. And you know what that means. People don't want to say it. And it's concerning. So that is why I think we have to save emergency medicine. This is not just some esoteric academic argument. I actually think we are at a pivotal time where if we don't actually redefine what we do, this specialty could be lost. I don't want that to happen because I truly believe in this specialty.
All right. So those are some of the other factors. There's accessibility, increasing patient complexity, a rising burden of unmanaged chronic disease, physician and nurse staffing shortages, and also a lack of beds for admitted patients.
Yeah,
that's some heavy stuff there, Dr. Atkinson. I just have to take a long, deep breath there.
I know it is. And we didn't even really get into the lack of hospital beds because I think we've covered that in many other venues. And I know, actually, I think Grant here is someone who has some real insight into that issue in terms of how big a problem it is. And maybe it's not as big as we think.
So, Dr. Innes, could you comment on the lack of hospital beds as a contributor to this problem we're having in emergency departments?
Absolutely. That's the biggest problem for emergency departments, of course, is boarding patients in emergency departments. And so we have much or most of our ED capacity occupied by inpatients who are not able to get access to an inpatient bed. And as a result, with limited capacity, we end up making sick people wait in emergency department hallways and waiting rooms. And so our problem is largely to lack of access to hospital care. But as Paul alluded, this problem is probably not as bad as we all think. We did some research a few years ago, and we looked at about 28 big hospitals across the country and found that the average emergency department in urban Canada has a high acuity access block of about 46,000 hours per year. What that means is that outside each of these emergency departments, there are CTAS 1 to 3 patients waiting to get a care space for accumulated 46,000 hours a year.
And just for our non-Canadian listeners, could you just explain what CTAS 1 to 3 means?
Okay, so CTAS 1 is a resuscitation, CTAS 2 is an emergency, and CTAS 3 is an urgent patient, so somebody with abdominal pain or chest pain. And so if as emergency departments, our primary concern is emergent and urgent patients, then these are the patients we have to get into care. In order to get them into care, each hospital would have to come up with about 46,000 hours of bed or stretcher space. Now, an average hospital might discharge 40,000 inpatients a year. So if you reduced an inpatient length of stay by 90 minutes, not 2 days, you could solve the problem. If you reduced consult delays from the emergency department to an inpatient service by a couple of hours, you could largely solve the problem. If you increased emergency department efficiency and reduced our discharge lengths of stay by an hour a patient, you could solve the problem. So this is a problem that actually can be solved with or without new capacity, and I think it's not likely governments are going to build large numbers of new hospital beds in the future, or at least in the near future. So there is a place for efficiency and accountability for each program to actually look after its patients. You asked earlier about, why is the solution for ED boarding upstairs in the hospital? You just have to ask yourself, what are those patients waiting for? They're waiting for an inpatient bed. And emergency departments cannot solve surgical waits or medical waits. EMS cannot solve emergency care delays. Everybody has to deal with their own waiting patients. So I like to say that the program that's causing the wait should have the waiting room.
So it's about a shared responsibility, in other words. Is that fair to say?
Maybe not. I like to advocate for accountability. And what I mean by accountability is if you are the Department of Emergency Medicine, you are accountable to all of those arriving patients, and you got to figure out how to get them seen without leaving them for EMS to deal with. It's your accountability. And inpatient programs have an accountability to figure out how do we provide care to these patients that we're holding in emergency department because it's crippling the emergency department and because our patients are not getting the care. So I think that there actually is specific accountabilities for each program. And what I often hear is, oh yeah, but it's everyone's accountability, right? It's shared accountability. We're all in this together. And if it's a shared accountability, then nobody's accountable. Somebody actually has to be accountable. Otherwise, you can just say, oh, it's everyone.
And I think this is a cultural challenge. We in New Brunswick, which is a very small province, and therefore perhaps we're able to move things in a direction that without as much political complexity, but we have managed to get our two health authorities, and thanks to the CEOs in each, to set up a task force for this exact problem. And I was pleasantly surprised, and maybe I should not have been surprised, but I was, that they acknowledged Grant's point. And we've actually come up with some targets that are now in place across the province as of earlier this year. And again, numbers are arbitrary, but the principles are that we should be able to offload ambulances within 20 minutes. We should be able to have consultations completed within 2 hours. That no patient who's being admitted to the hospital should stay in the emergency department greater than 8 hours from arrival. But the key part to this, it's the footnote to that last one, is that at 8 hours, they should become the responsibility of the admitting team. So that's a game changer. And if we can actually get that implemented to say that, okay, you've accepted this admission and at 8 hours, it's now your patient, both from a nursing, administrative, and medical perspective, that's a game changer. And so, of course, the other parts of increasing efficiency within the emergency department, within the hospital, discharges, ALC patients, all of that is key to making this work. But I think the acknowledgement that there is accountability for admitted patients who are actually not really admitted is key.
That gives me hope after all of this doom and gloom we've been talking about. And we're kind of segueing nicely into solutions. So that's fantastic in New Brunswick that at least there's an acknowledgement and there's some hard endpoints that there's a goal to achieve that will start to help fix these problems. I'd like to talk more about the solutions. So, as you were saying before, you were accused of just complaining in your article. I don't see it as that. I think it's quite clear that what we've outlined here are some real problems that people may not have vocalized quite so clearly and eloquently. And I think it was really important that was vocalized. So again, congratulations on having the audacity to publish that. So we've got these problems, we've outlined them. Let's talk more about solutions. So perhaps the easiest way to do this is you two can take turns talking about solutions for these problems with access block, accessibility, dealing with patient complexity, etc.
Okay, and if it's okay, I might kick off with this concept that I think is captured in the title of the paper, which is what is emergency medicine, and the concept that is less more. Because you have to really try to get your head around what are we trying to say by is less more. Grant has outlined the types of patient who may be waiting, such as a subarachnoid hemorrhage, such as a leaking AAA, such as a young lady with an ectopic pregnancy. They can all be hidden in a crowded waiting room or on a hallway, an elderly patient with sepsis who doesn't mount a fever. There's all sorts of true emergencies that are waiting while we are perhaps dealing with anticipated failures of the healthcare system, people who have social needs, people with chronic illness who have a slow decompensation, all the things we've talked about. And so is less more? What does that mean? Well, I think it means somehow we have to define what our patient population is, what our skill set is, and we have to focus on doing that as our primary mission. And that's a difficult conversation, especially here in Canada, because the numbers of the everything and everyone are going up. It's not just anything now, it's everything. So it's time for us to redefine what an emergency medicine skill set is and what an emergency patient is, and put systems in place, I believe, to protect those patients. So that's the challenge. And so you might say, well, what's your answer to that, Paul? I don't know, but I think we have to really think hard about defining it and then looking for ways to make those patients ours. And yes, will that mean other patients have to wait? For sure. But patients are waiting. What we have to do is ensure the right ones wait or have an advocate for a better approach for them. And I think those are some of the other solutions we'll get to. What are those other approaches for those folks who aren't truly emergency patients?
I have to pick up on this because I think this is actually the core reason why less may be more. And so I have to tell a story. About 5 years ago, my mother had a stroke. So she was taken by ambulance to the tertiary stroke center where she was triaged to a hallway on an EMS stretcher because the department was full and the waiting room was full. So after 3 hours, the EMS crew was getting worried. My father was getting worried. He phoned me. I phoned my friend who went down and examined her in the hallway, called the stroke fellow, and she went to the cath lab for a clot extraction, but did not do well. And I described this as a Where's Waldo analogy. There's one critical patient out in your waiting room, but you can't see him because there's all these other patients and there's all these other complex tasks that we're now doing. So The unbridled demand on emergency department is distracting us from our core mission, and that's, I think, the most important reason why less may be more, because we are not doing our core job.
It's a complex question, how to implement less is more. We might not have time here on the podcast to really sort that out. And while you're both experts in your fields, you're not the be-all and end-all administrators of emergency medicine in Canada, but perhaps just some ideas about how we can start to get across that less is more, and what would that actually look like in terms of, practically speaking. Any ideas how we could implement less is more?
Well, it won't be fun. The fact that we have triage anyway, even within the less, speaks to the fact that we don't have the resources to meet everyone's need immediately, right? So the first principle is that there's always a choice. You always have to prioritize. That's the game we're in. We chose it. We don't sift through the referrals and put them in a nice orderly fashion, schedule them over the next month or so, right? We triage what is necessary immediately, and then we work through. Administratively, you mentioned administration. I think that there will be challenges here, and I hope that administrators, whether that's us as leaders in emergency medicine, as department heads, but I hope also as chiefs of staff, medical directors, and CEOs will take the approach of actually respecting the accountability framework. And that's where I would start. I'll give you a story. When I became department head, I decided to take a stand and ask for something from our colleagues in other specialties, which was very simple. Do not send anyone to the emergency department for an emergency medicine consultation, as I like to call it, if you're sending someone, without speaking to us. So that became a standard. No one liked it. I received much criticism for this, but our group was behind this approach. And in fact, some of our administration was behind this approach. And I would say that it is now the norm that if anyone is sending someone in from the community, no longer do they just scribble a note and send them or tell them to go. We've asked for all the out-of-office messages or the after-hours messages to not say, go to the emergency department, but to rather give them the options of calling 811 or going online for online care, or calling your family doctor, or calling me tomorrow, because they all pretty much used to say, go to the emergency department. So we've asked, and many have complied, to remove that. And I do believe that culturally we now get a phone call for most of these. So what does that do? Does it fix the problem? No. But it moves us forward to where we can have a conversation, where we can actually say, we both want the best care for this patient that we're discussing. I'm the charge doctor, you're the referring doctor. It's the flip of a consult to a specialist. But we can say, is there an alternative to the 8-hour wait that they will face by something happening tomorrow, or by you scheduling some radiology this evening, or by facilitating some blood work? And yes, it takes another 2 or 3 minutes of your time on a busy shift, but it probably saves you an hour or two of having to deal with a certain number of patients. So I think communication and a collaborative approach to one by one dealing with these difficult cases together, and saying who's truly accountable for this patient and how together can we find a pathway. I think that is what I would offer as potential beginning towards a solution.
It's very interesting. Up until very recently, any physician who calls in who say they want to send a patient in, and I pick up the phone, literally I say, okay, yeah, sounds great. Yeah, send them in. No problem. We'll take care of them. And I felt proud saying that. And this really flips it on its head. It's interesting that in emergency medicine, we're often consulting another specialist. And so some of us have had frustrations getting patients to where they should go. And so my guess is that we don't want to be that difficult consultant who's not taking a patient. And so, we've been there so many times that we say, oh yeah, sure, send them in. So this is a really different way of thinking. It's almost like I would need training to know how to handle someone calling in where I truly feel like perhaps the emergency department is not the best place for them to be, and how to make sure that the patient is getting the best care that they can. That is sort of a paradigm shift in how we think. and how we communicate with other physicians.
I think it is, Anton. And to be completely honest, sometimes there is no alternative. And I think that is the next part of the conversation, is that we haven't built in Canada, or perhaps globally now, the accessible alternative options for these patients. And so even after that conversation, you may end up saying, okay,
right,
send them on in, because that's all there is available, right?
I would think that even though ultimately you know that you are going to accept the patient, just having the conversation to help the consultant realize what the issues are, the more that the consultants are aware of these issues, that's, again, perhaps a beginning to a solution there. Dr. Ennis?
I was just going to say that if a physician can't manage a patient and needs help, they should always send that patient in, and I would never refuse that patient. But if most of the demand that we're seeing, that's not the situation. And if a patient is coming because the doctor's office is closed Monday and Friday and after 3 p.m. and there's a message that says go to the emergency department, I'm not happy with that. That's somebody abrogating their responsibilities. If a program says, no, we don't deal with patients after 5 o'clock, so we're going to send them to the emergency department, that's not appropriate either. I'm happy to help anyone out of a crisis and manage any patient that has to come, but it's kind of reached a point where we can't be everything to everyone. We can't be the universal contingency plan because it's compromising our ability to do our primary work.
I do also think that Grant is onto something when he talks about his loved one not getting the care. How do we draw that line in terms of what an emergency is? Because that's part of this solution, right? We have to think really hard. Where is the safe line that we could start to provide a little pushback and a little nudge and say, well, maybe there's an alternative for this? How do you define that? Because the mantra out there is often, well, it's my emergency from the patient's perspective. And I've heard very respected emergency physician colleagues say, well, if it's your emergency, I'm here to help, even if that means you just need a prescription refill. Because the truth is, for that patient, that could be an emergency if that is a critical drug and they have no other way to get it. But that does not excuse the system for not having put in place a way for that prescription refill to happen outside the emergency department, right? So this is difficult. It's really difficult. I'm not pretending this is an easy conversation.
You asked about solutions, and my number one solution, which I think is the critical solution, is an accountability framework, and I'll explain what that means. So in Canada, we don't really have a healthcare system. We got a bunch of people who are healthcare providers, and they go out and do what they do. But it's not organized, and there is no accountability framework. And so critically, programs are not expected to be accountable for their waiting patients. If any given program, a hospital program, for example, determines they are not able to manage their queue of patients, the default is to just close the front door, stop inflow, and say, the emerge will look after it. So if you close beds for budgetary reasons, you have sick calls, if you have seasonal closures to allow staff to vacation, the assumption is the emergency department will just hold more patients. If an inpatient is discharged but they can't get a ride till 6 p.m., the assumption is, well, one more emergency stretcher is going to be blocked today. And so it's almost like access block is not a problem, it's the solution. It's a default solution. So if there's too many patients, there's not enough care supply, you close the door. And the workload is controlled, your waiting patients are out of sight, out of mind, your staff stress is relieved, your budgetary challenges are mitigated, your care shortfalls become somebody else's problem, and your program is protected from the demand stresses that otherwise would mandate that you improve and innovate. So this ability to just say, we're going to manage demand capacity mismatch by closing the door, it's the way we solve problems in the healthcare system. And Emerge does it as much as anyone else. We look around, we say, oh yeah, our stretchers are full, put the patient with the stroke out in the hallway.
I think the other principle is that no system should have a single point of failure. But there's where we are. What's our first line of this paper? Emergency departments are failing. We have to acknowledge that. We can't call this success right now. People are burning out and leaving. Patients are leaving. Left without being seen rates are going up. Adverse events are going up. Complaints are going up. We're failing. If you say our job is to look after everyone who comes to us, we're failing. So I think we have to elevate this to a societal and political level and say, we've ended up with the emergency department being the place for all unscheduled care. Not all, but most. And it's failing. So what are we going to do? Are we going to say, well, it's your fault and fix it so that we can continue with this model and maybe fail again? Or are we going to say, as Grant has proposed, let's look at this system, or let's create an actual system. Let's put in the funding, the direction, the incentives, the guidelines that don't have the rest of the healthcare system shut down at 5 o'clock and all weekend, that have options for people. And water flows downhill. And when those options are available, people will use them.
So we've talked about a variety of solutions thus far. Any more solutions you have to our, quote, failing emergency departments, unquote?
Well, I guess one thing that I would propose for all programs, for emergency departments, for inpatient programs, for long-term care programs, is the concept of triage in. So when somebody is at your front door, when somebody's referred or arrive, the default position is not to block them and block access, but triage them in. So this is very stressful. It puts stress on systems, but there's this thing in chemistry called the law of mass action, which says that the rate of a chemical reaction is proportional to the concentration of reactants. And it fits very much in healthcare systems where the rate of a process is proportional to the concentration of patients queuing in front of it. So if you don't see patients in front of you, your processes slow down, the need to innovate disappears, the need to solve problems disappears. If you bring those patients in and you're actually faced with your demand, you can make incredible improvements. So just to change the default mode to, yes, let the patient in, open the front door.
So many thought-provoking points we've made. I do welcome any EM Cases listener to use the comments box at the bottom of the post on the EM Cases website. I'm sure we can have a very robust discussion online. Before we wrap up, I'd like to ask you if there was one call to action, so to speak, when it comes to redefining emergency medicine and improving overcrowding, what would that call to action be?
You say one. Can I give you three? But it'll be very succinct. And we've referenced in our response to some letters in CGEM an article that I know self-citing is a bad habit, but if you would permit me to cite one, a paper that was called Just Three Things. And I wrote it just before I became, or as I became department head, and it was a contemplation of what three things I felt could help save emergency medicine. And it's very simple. It comes down to, number one, resources. Number two, skill set and training. And number three, compassion. I think if we have the resources in the system, then that's a start. You have to have enough resources across the system. And you have to make them accessible, not bunched up here, but across a timeline. You have to have the right skill set. So perhaps part of emergency medicine, less is more, will be, well, less, but maybe a little more than we were used to, because we will have to take on some of this chronic disease management, certainly in the short term. So we need a skill set, but we also need a skill set within primary care, nurse practitioning, specialties that deals with unscheduled care. And perhaps that skill set hasn't been there. So it's not just us. And finally, the compassion. I believe strongly in this. I really do. I think that when I look back on my lengthening career, I say what actually makes a difference. It's the compassion for those around you. It's the compassion for your staff. It's the compassion for your colleagues and other specialties. It's the compassion for your patients. And it is the compassion for yourself. So that when you go home, you say, I did my best. I tried hard, I tried to change things, but I provided care in the best way I could for those patients today, for the people I dealt with, and you have peace with that.
The compassion part, it's almost like we planned this in advance or something, but we didn't, Dr. Atkinson, because one of the things I've been lecturing on the last couple of years since I did our podcast with Barbara Tatum on compassionate care is compassion in medicine. And one of the things I've been adding on top of what we covered in our compassionate care episode is the idea of self-compassion. And that's something that I think is so important. As you said, there's compassion for your patients, there's compassion for your colleagues, compassion for everyone around you, but also compassion for yourself, because it's very hard to deliver compassionate care without having compassion for yourself. And many of us in emergency medicine are very hard on ourselves. We want to be the best that we can be. It's music to my ears to hear that there's other physicians out there thinking in those terms. Dr. Innes, if you had one, or I'll give you two or three, because Dr. Atkinson gave 3 calls to action.
I think I only need one. And this is a call for emergency department leaders to take on this as a very difficult but achievable task. And when I talk to ED heads, they often say, look, this is too tough. This is outside my sphere of influence. And there's nothing I can do about this, but they're wrong about that. And so I have to tell another short story. Quite a while ago, when I was a department head in a different city, we had a very bad month with several waiting room disasters, and we addressed these at a monthly M&M rounds. And many of the physicians couldn't make it to the M&M rounds, so as soon as they were over, I went to my office and I emailed a copy of the rounds to the other physicians. And I wasn't timing it, but I think it was less than 4 seconds later, I got a phone call back from our hospital CEO who said he'd gotten a call from the regional CEO who'd gotten a copy of an email of our rounds, and she was not happy. And so this had sort of reached higher levels of leadership. And within 2 months, we implemented the overcapacity protocol and had major improvements. And I subsequently met with the CEO. We had a very pleasant meeting. She was very positive, and she said to me, "You have to solve this problem." And I said, "What do you mean, doctors?" And she said, no, emergency doctors have to solve this problem. You are the ones that are motivated, and you understand what's going on. And I took that seriously, and she is exactly right. So emergency leaders have to, first of all, understand this problem. Why is it happening? They have to sway other leaders. They have to sway other department heads, so medical advisory boards, flow committees, quality committees, hospital boards. They need to tell data and stories. They need to understand that actually most of the leaders in the system are decent people and want the right things to happen. So later I did that in Calgary, and I was, after about 6 months, the other physicians on the medical advisory board said, you know what, we don't like this idea, but it's the right thing to do, and we have to introduce these accountability strategies. And we made big changes. So it's difficult, but it can be done, and nobody else in the system is motivated like emergency leaders should be motivated to do it. And so if you don't do it, nobody's going to fix the system.
We're going to leave Saving EM on that call to action. Thank you so much, Dr. Innes and Dr. Atkinson. Let's shift gears now and talk about assessment and management of traumatic pneumothorax. Now, back in episode 158, Management of Primary Spontaneous Pneumothorax, we covered the conservative management of larger spontaneous pneumothoraces, some procedural tips and tricks, which we highlighted at the last EM Cases Summit. We made that video available on the EM Cases website, the one called Placement of Pigtail Catheter Chest Tubes for Spontaneous Pneumothorax. Check it out if you haven't already. Anyhow, we're here to discuss the ins and outs of traumatic pneumothorax, which have some overlap with episode 158, but there's some subtle differences that we really need to know. But before we get into traumatic pneumothorax, here's a message from our sponsor, Metricade. Metricade will be at ACEP this year in San Francisco. They'd love for you to drop by their booth where they can walk you through their incredible scheduling system and explain how docs get the shifts they want while minimizing the wrath of sleep deprivation, and how their app and website is super user-friendly to make it work for your ED. At the ED I've been working at since 2010, we've been utilizing the wonders of Metricade for almost a decade, and I really couldn't imagine working without them at this point. Every ED that I know that's hired Metricade has never gone back. Metricade hopes to see you at ACEP. All right, now on to traumatic pneumothorax. It's my pleasure to welcome to EM Cases Dr. Mathieu Toulouse, who's going to be talking to us about traumatic pneumothoraces. Now, just like in spontaneous pneumothoraces, practice patterns are sort of all over the place. And there have been recent guidelines published by the Western Trauma Association. They have an algorithm there that we're going to go through to hopefully work towards a more standardized approach to traumatic pneumothoraces. So, Dr. Toulouse, welcome to EM Cases.
Oh, thanks so much for having me. And I agree with you 100%. Up till recently, management of traumatic pneumothoraces has been almost more art than medicine, or more art than evidence-based practice. And one of the main advantages of having an algorithm like this one is that it allows us to have a more systematic approach based on objective criteria and the best available medical evidence, or at least expert opinion. We do know now for some time that not all pneumothoraces need to be drained. And this changed quite a bit when CT scan became more ubiquitous. We noticed that we were diagnosing more and more pneumothoraces, and we well knew that some of those pneumothoraces weren't yet getting drained before and patients were doing well. We now have evidence that shows us that even overt pneumothoraces can be observed. Knowing that, and knowing that tube thoracostomy is not without its complications. The complication rate is actually between 10 and 30% if you look at available literature. And knowing that any patient that gets a chest tube will also get pain, I think we need to choose our patients wisely. Thankfully, the WTA helps us in that regard and says that when we want to decide whether we need to drain a pneumothorax or just observe it, we need to ask ourselves two questions. The first and more pressing question is, what is the cardiopulmonary status of our patient? If the patient is hemodynamically or physiologically abnormal, then if we think that abnormality is caused by the pneumothorax, it's pretty straightforward. It needs to be drained. Now, that may seem fine and dandy for a patient who's overtly abnormal physiologically and for whom you can see the pneumothorax on the chest x-ray. But we know also that we're using more and more ultrasound now in our resus for trauma patients, and we will be faced sometimes with patients that are very sick that do not have a pneumothorax when we look at the supine chest x-ray, but will have absent lung sliding. And I bring you back to the actual wording of the WTA. If we think the physiologic abnormality is caused by pneumothorax, we should drain. Now, what about that occult pneumothorax? Well, looking at the literature, we can see that not all occult pneumothoraces are created equal. Actually, some case reports show that they may be as large as 80 millimeters, which is by no means small and for sure well large enough to cause a physiologic abnormality. Now, thankfully, the WTA doesn't just offer us a comprehensive algorithm that we can walk through. There's also an accompanying text. And when we look at the text, the WTA tells us that if we're unsure, we should just go ahead and drain a pneumothorax in a patient who's hemodynamically unstable, which is a good reflection of what people are doing in practice. If the patient cardiopulmonary status is more normal, or if the patient is stable, then we can move on to the next question if we want to decide whether we should drain the pneumothorax or not. And according to the WTA, it should be based on pneumothorax size. Now, for most of this, there isn't any super solid literature. It's a quasi-surgical procedure and it's trauma. So we're not talking RCTs and we're not talking huge studies. But if you look at the literature as a whole, it does seem to be correlated to the chances of having a successful observation of the pneumothorax. So the smaller pneumothoraces have a better chance of being observed successfully, and the larger ones have a larger chance of failing observation. So for the WTA, for the chest x-ray, they suggest that the cutoff be placed at 20%. Now, as hard as I could look, I could not find one paper or one convincing source that told us that the 20% cutoff is actually a valid one. It's a good reflection of what people do in practice. But if you look at the papers that have observed or looked at observation of overt pneumothoraces, sometimes they look at the measurement of the distance between the parietal and the visceral pleura in centimeters or millimeters. Sometimes they look at the percentage. One of the issues with using the percentage is that it forces you into using one of the formulas, either the Collins, the Lights Index, or the Ray and Choi methods, which in my mind are good, but they're not as user-friendly as just measuring the distance between the parietal and the visceral pleura, which is what we tend to do for medical pneumothoraces. I'll remind you that the American College of Chest Physicians suggests that we measure the distance between the parietal and the visceral pleura at the apex. And for medical pneumothorax, if it's more than 3 centimeters, it's what consists in a large pneumothorax. For the British Thoracic Society, if you look at the hilum and you measure the distance between the same two structures, if you surpass 2 centimeters, then you're faced with a big pneumothorax. In trauma, we don't have such guidelines. There are papers that suggest that maybe 2 centimeters at the apex is a good cutoff to use, but it's not something that's used ubiquitously, and it's not something that's based on solid evidence. So we're still stuck with that 20% from the WTA. That seems to be more expert opinion than actual evidence-based recommendation. Now, there are a few other important things to mention here when we're talking percentages. The first one is that it's most likely not so much applicable to our supine patients. When we do a supine chest x-ray in the trauma bay, we know that the sensitivity for detecting a pneumothorax is around 50%, so quite bad. And as I've mentioned before, an occult pneumo, if that's how you define it, on a supine chest x-ray may be large. So if you're using that cutoff of 20% to decide that you can observe a patient safely, I think you shouldn't be using a supine chest x-ray. It's probably best used for those patients that are well enough to be upright and have a proper PA chest x-ray. Now, obviously, if you have a supine chest x-ray and it shows that your pneumothorax is 20% or larger, then if anything, it's only going to be bigger if the patient at some point is well enough to stand up. So I think it's reasonable to go ahead and drain. The other cutoff that can be used for size is to use the images on CT for stratifying who needs a chest tube and who can be safely observed. The measurement that's proposed by the WTA here is a little bit more precise. They say that we can use a distance of 35 millimeters when we measure the largest air pocket. So that's measuring from the chest wall to the mediastinum radially at the largest air pocket. And if we surpass 35 millimeters, according to this algorithm, we should drain the pneumothorax. This is based on a series of papers that have been published by a group of doctors, including Dr. Moya, who incidentally has also participated in elaborating this algorithm. But they looked at retrospective data from a level 1 trauma center in Boston initially, and they found that when you use the 35 millimeter cutoff, it actually predicts success rate of around 90%, which patients will be able to be observed successfully without drainage. If you go beyond 35 millimeters and you try to observe, the failure rate is actually around 40%. So it seems to be a good cutoff, and it seems to be a good way to dichotomize your patients. You know, this came from Boston. After that, they looked at data from another level 1 trauma center in Milwaukee, and it again showed the same results. And this center used it as a practice management guideline and then did a before and after study, and again showed the same results. It seems to be a good way to stratify your patients, and this is gaining acceptance. If you look at various sources, it's something that's being cited as a safe way to approach your patients.
So even for pneumothoraces found on CT that are 3 centimeters from the apex, you can simply observe those patients. What about if those patients need to be vented for whatever reason? I mean, I would really worry that with a 3 centimeter pneumothorax on a ventilator, you'd have to watch them like a hawk to make sure that they're not going to progress to a tension pneumo.
Now, the question about positive pressure ventilation, or PPV, is very interesting. You know, the short answer to that is we don't know at this point. If you look at the text from this algorithm, the text that's accompanying this algorithm, it seems to suggest that PPV doesn't have an impact on the outcome of pneumothoraces, and it shouldn't necessarily be something that changes your decision to observe or drain. Now, that being said, if you look at the literature that was available when this was published, it was papers that looked at the outcome of occult pneumothoraces. So pneumothorax that you cannot, by definition, that you can't see on chest x-ray. Doesn't tell us what the size of those pneumothoraces were on CT. And for the most part, up to 35 millimeters, you will have some of those pneumothoraces that are overt for sure. You're not only looking at occult pneumothoraces. So the earlier literature that was a small number of patients seemed to suggest that when those patients were vented, it didn't change the outcome of their pneumothoraces. After this guideline was published, the OPTIC trial was published. It's a multi-center randomized control trial in which many centers from Canada participated, and they looked at the management of occult pneumothoraces for patients that were vented. This is a bit of a complicated article to analyze, partially because what they're looking at as a primary outcome was a composite outcome of respiratory distress. Now, that being said, they did look at what happened with their patients, and it included a fair number of patients, more than what was in the previous studies. And a few things can be concluded, or a few things are suggested by the results from the OPTIC trial. The first one is that, as we had thought more recently, for patients that get vented for an OR, it doesn't really seem to change anything. The outcome seems to be the same. If you decide to observe them, they're not going to go into tension pneumo right away. You're not going to have to drain them urgently. They seem to do just as well as the patients that don't have to get vented. For the sicker patients, however, the OPTIC trial suggests that it does make a difference. Those patients that went to the ICU and that were vented for 4 days or more had a significantly higher failure rate in their observation. So the failure rate went up to 40% and upwards for those patients. So it definitely seems to change something. There is also another paper that's interesting that was published just this year that looked specifically at the outcome of observing occult pneumothoraces in penetrating trauma, which is a subpopulation. And a lot of experts believe that the disease is not exactly the same. And, if you take a second to think about it, it makes a lot of sense. It's not exactly the same process. And it's possible that those patients don't really behave the same way as the blunt trauma patients. And in that study, which was a fairly small number of patients, the patients that were vented that had suffered from a penetrating trauma had a higher rate of observation failure than the ones that were not vented. So it seems to change something for the penetrating trauma patients, seems to change something for the patients that are sicker, vented for longer. And I'll bring you back to what I said initially. The papers that we have are on occult pneumothoraces. If we're starting to observe 33 millimeter pneumothoraces on CT, these are probably not occult. We can probably see them on the X-ray. We'll see them on the CT. We'll hum and haw about them, and we'll decide that if the patient's well enough and we feel comfortable about it, we'll observe them. Now, if this patient is vented, he probably needs to be watched over closely. And I don't know if I watch over closely like a hawk, but I would definitely make sure that everyone on the team is aware that this patient has a fairly large pneumothorax, that we're pushing the envelope, and that we've decided to observe. And, we're emergency physicians. We're discussing amongst emergency physicians. These patients are not staying in the ER. They're going to the ICU, right? So I don't think we can make this decision alone by ourselves. I think we need to talk to our consultants. You need to talk to the trauma team. You need to talk to ICU, and everybody needs to be on board. If anybody doesn't feel comfortable about this, then this is a no-go. It's not going to work. So, it's possible that after discussion, you'll have a group that's a little bit more progressive, a little bit more aggressive, that are willing to go that route and take that chance, if I may so speak, with that patient. But if the person who's the primary care physician for this patient is not comfortable with that, then you should probably just go ahead and drain it.
All right. So that's a really good explanation of who is safe to observe and the importance of having everyone on board. What about the size of the tube? So, in medical pneumothoraces, it's pretty well accepted that one of the 14 French pigtail type tubes is more than adequate, and there's usually very little reason to have a larger tube. Trauma is a little bit different because you're more likely to have some blood mixed in there. And, in the old days, I have a few gray hairs, so I can remember the times where they stuck these giant tubes into everyone. And it seems like we're heading towards smaller and smaller tubes. So the question is, are pigtails adequate for every traumatic pneumothorax, or is there still a time where we would use a larger tube?
So this is an interesting question. And, you're referring to the larger tubes, the 36 to 40 French size chest tubes were being used at some point. And these make absolutely no sense if you ask me. So for the average adult, the distance between two ribs is about 9 millimeters. A 40 French chest tube is 10. So
ouch.
There's no way you're achieving anything with that. You're limited by the amount of space that's available between your ribs. And even a 28, so even that is slightly larger than 9. So for the average patient, when you stick in a 28 French tube, you're crushing that neurovascular bundle. So that's morbidity right there. So technically, for any patient that gets a 28, you're causing them a lot of pain. And sure, you'll give them pain medication, but they probably will find that very uncomfortable. There's a shift, right? This has been happening for years now because the 3640 have been left behind. We're now moving to 2832. And the people that are more progressive, as you said, are using the pigtails more and more. And these are being used for medical pneumothoraces. They're also being used for traumatic pneumothoraces. The one paper that everybody refers to say that we have evidence to tell us that using 14 French pigtails is safe is a paper that's coming from Tucson, Arizona by a group of doctors that are quite aggressive at promoting the use of pigtails. It was published in 2014. The one issue with that paper is that its primary outcome was looking at pain perception. Okay, and they wanted to measure a significant difference in pain perception between the conventional chest tube and the pigtail catheter. So their study was powered to measure that, and it included 40 patients. So I'll suggest that they didn't really have great power to measure any difference in success or failure rate between conventional chest tubes and pigtail catheters. Now, that being said, there are other papers that look at, and they're mostly observational papers, that look at small conventional chest tubes, mostly from Japan. It seems to be a trendy in Japan for ER doctors to stick in 20 French chest tubes for pneumothoraces, traumatic pneumothoraces, and the patient seems to do well. We also have, like you said, on the medical side of things, evidence that tells us that it's safe to use pigtails for pneumothoraces. One of the main concerns with the pigtail in trauma was that for many of those patients, there's a bit of blood associated with the pneumo. Whether you see it on imaging or not, once you stick the tube in, you see there's blood coming out. And there was concern that pigtail could get blocked or occluded and would increase your risk of failure of drainage and increase your risk of having eventually a tension pneumo. Now, the same doctors from Tucson, Arizona have published other papers that have also limitations, but that suggest that using pigtails for hemothoraces is also safe. And it's something they're doing in their center. And to give you further encouragement in using pigtail catheters, the East just put out its latest guidelines on management of traumatic hemothoraces. And for the stable trauma patient who has a hemothorax, the East put out a conditional recommendation in favor of the pigtail catheter. So, if you have all this evidence telling you that it's probably even okay to use them we're not going to get into that, but, in certain instances to use them for a hemo, I don't think you need to worry about a small amount of blood causing failure of your pigtail for a draining at pneumothorax. And one thing further that I would add on this is that, like it or not, like the quality of evidence or not, this has gone into practice. It's not going into practice, it's gone into practice. In 2019, there was a survey whose results were published that asked East members what their practice was. Basically, what do you do with this? What do you do with that? And for a traumatic pneumothorax in a stable patient, a majority of the East members would go to a 14 French pigtail, and a certain number of them would go, and off the top of my head, just above 50% going to the pigtail, and another 15% going to the 20 French chest tube, conventional chest tube. So you have 70% of the East, and that's, result that's published in 2019. So people that were asked that question before 2019. So people are doing this already. And we're not hearing any stories of patients doing terribly and huge complication rates and black box warnings coming out against pigtails for traumatic pneumothoraces. So I think this is a safe way to go. And if we bring it back to what we're discussing, the WTA's algorithm, this is actually what they suggest. If you look at the algorithm itself, it says to use a small bore chest tube. And if you look at the text, it says to use the smallest bore chest tube available. But you did say, are there exceptions? In the text, the WTA says that if there is a significant component of hemothorax, it may be reasonable to choose to go to a 28 French conventional tube, which is a bit surprising because in their own algorithm on hemo, they recommend using the pigtails. But, they're giving you permission, quote unquote, to use the 28-French chest tube if you feel like there's an indication. It's not a crime. It's okay, but it shouldn't be your go-to according to this algorithm. And I think this is something that's okay to move towards. Same caveat or same thing that I would add as what I've said before. For the most part, you're doing this to a patient who's going to someone else. So if you can, make sure you have buy-in with the rest of your team and make sure your trauma team is okay with that. But I think you can take up that conversation with them and say, look, we've been putting in these big chest tubes for our patients, and it looks like, we have guidelines that basically tell us this is a safe way to go. So should we change our practice?
Absolutely. One last question that sometimes comes up is, do all patients with traumatic pneumothoraces require antibiotics?
So this is an interesting question. And I mean, it's interesting, but also unexciting if you ask me. I got a bit passionate about the other questions you asked me. This one, I don't know. I think the jury's still out. The WTA takes position and says that we should use pre-procedural antibiotics when we do a tube thoracostomy, whether we're talking about a hemodynamically unstable patient or a hemodynamically stable patient. In 2012, the East put out its own recommendations, and they haven't updated it since. And the conclusion of their guidelines was that there was insufficient evidence to make a recommendation either in favor or against antibiotics. And the existing papers are fairly heterogeneous. They use different types of antibiotics, different durations. The evidence isn't that convincing. And they conclude that this will probably not change for them until there is a much better paper that comes out, an RCT with a large number of patients. That being said, since this management guideline was published by the East, 2 papers were published. One was an RCT from Iran, published in 2014, that looked at most of what the proponents of antibiotics do. So ANSEF for 24 hours when a tube thoracostomy is performed versus placebo. And those were only blunt trauma patients, and there was no difference. There is also an observational paper published in 2018 by the AAST that looked at the outcome of patients that were receiving pre-procedural antibiotics versus the patients that weren't. And again, same conclusion. No statistically significant difference. And just to be precise, what they're looking for is a difference in the number of patients that get complications like empyema and pneumonia. Those are the things you're trying to prevent with the presumptive antibiotics. The WTA bases its recommendation on meta-analysis that was published in 2019 that put all the existing papers together and that concluded that there was benefit to providing pre-procedural antibiotics in reduction for empyema and pneumonia. Like I said, I think that hasn't changed anything to the quality of the evidence that was there. It's still fairly heterogeneous. A lot of those papers looked at providing patients with antibiotics for up to 7 days, which is not what's being suggested here. It's just 1 day. So I don't think that necessarily what's being suggested here is that evidence-based. And interestingly, there was another meta-analysis that was published in 2021 that looked basically at the same thing and whose conclusions were a little bit different. The authors dichotomized the patients between penetrating traumas and blunt traumas. And when they stratified the patients like that, they found that for the blunt trauma, there seemed to be no benefit in providing pre-procedural antibiotics. For the penetrating trauma, there was a benefit in reduction of empyema and pneumonia, which, when you think about it, makes sense, right? So sometimes when we have a very sick trauma patient, take away the tube thoracostomy or the need to put in a chest tube, sometimes they're just so badly cut and so dirty that we do give a dose of antibiotics just because we figure it's going to help them. And we're wondering about, a possible open fracture, a possible arthrotomy, a possible procedure that may have been not as aseptic as we would have liked. So I think, there's kind of some justification to that, or this makes some sense. But, to bring it back to my conclusion, I think the WTA takes position on this. They recognize themselves that this is still controversial to this day, and I think the jury's still out. I think if you look at various institutions across Canada, and I'm guessing it's the same in the US, there's a great deal of variability. Some have bought into this already. They're doing it, and some haven't, and they're not doing it. At my hospital, we're not doing it, and I don't see this changing anytime soon. I don't think that we have any strong advocates for doing this. Now, the one thing that I can't really speak to is what the implications are of this as far as antibiotic stewardship, right? It's just one dose. I don't know what the impact is. I couldn't find any data on that. Is it really going to cause harm? To have a really educated opinion on this, what's the NNT versus the NNH? I don't know. But I think at this point, it's kind of dealer's pick. If you feel that it's going to change something, you can say that there's no good evidence either way. And if you feel like it's not going to change anything, you can say that there's no good evidence either way.
All right. Suffice to say that it should not be your priority. I mean,
Definitely
there
not.
are a lot of moving parts with trauma patients. And some of us who don't take care of a lot of trauma patients and don't have algorithms in place, we're going to have some other priorities over antibiotics for a pneumothorax. So suffice to say that you wouldn't be faulted if you do not give antibiotics for traumatic pneumothorax. It makes intuitive sense that if someone has a dirty knife stuck into their chest, that they're going to require antibiotics. So those are the obvious cases. But otherwise, I think we can agree that not giving antibiotics is probably an evidence-based way to go. And from a priority perspective and from a human factors, you need a line, you need a nurse to give the antibiotics. There's other priorities. It should be low on your list. Is that fair?
Oh, I definitely agree. I think a lot of what we do for trauma, or when we successfully manage a complicated trauma patient, is just deciding how to stratify the interventions. Because for most physicians, we know what to do. If you had all the manpower and the resources you could imagine, you could probably do everything at the same time. But success really depends on providing what's most pressing in the right order and leaving the rest of the stuff behind. And you alluded to that, and I think this applies well to antibiotics. I fully agree with what you said. Yeah.
All right. Well, Dr. Toulouse, that was incredibly eloquent. I can tell you that if you asked me to talk about any topic in French, I would fall flat on my face and not be even close to as eloquent as you were speaking English as your second language. That was evidence-based, clear, and very educational. So thank you so much for your time.
Thanks so much for having me.
So I'll have the Western Association of Trauma Pneumothorax algorithm in the show notes, but I just want to review them here in the context of what we just talked about. So the first decision point is based on cardiopulmonary status. If you suspect that the pneumothorax is causing any significant hemodynamic or physiological abnormality, place a chest tube. They recommend one dose of pre-procedural antibiotics, but the evidence is weak and you probably only need to give antibiotics if it's a penetrating trauma victim and if you've taken care of other priorities first. They say that a finger thoracostomy or needle decompression may be performed while awaiting placement of the drain. If open technique is used, a small bore 20 to 28 French tube is acceptable, and you may also use a 14 French pigtail catheter. So that's if they have a physiologic abnormality as a direct result of the pneumothorax, regardless of the size of pneumothorax. Now let's move over to the other side of the algorithm for the hemodynamically or physiologically normal patients. So these are stable patients. For them, we need to evaluate the size of the pneumothorax by CT or by chest x-ray. I noticed that they didn't even have POCUS in the algorithm. Okay, so if a radial line drawn perpendicular to the chest wall in the largest air pocket on axial imaging is greater than 35 millimeters on CT or greater than 20% on chest x-ray, place a tube. If it's less than or equal to 35 millimeters on CT or 20% on chest x-ray, they suggest to observe the patient with repeat imaging in 6 hours, regardless of whether or not the patient is on positive pressure ventilation. So that's it on traumatic pneumothorax. We've got a couple more highlights of the CAEP conference in upcoming EM Quick Hits episodes, including one on medical legal myths and another on managing career transitions in emergency medicine with Connie LeBlanc, a Canadian legend in emergency medicine. And finally, there are only 5 spots left for Podcast Camp, my online medical education podcast production course in December. So if you or a colleague are budding podcasters or you're looking to up your podcasting game, please visit podcastcamp.org to register before it's sold out. The rebel himself, Salim Rizay, will be our keynote speaker, And we'll be covering interviewing skills, scripting, microphone technique, gear, voice editing, sound design, hosting, and posting. And of course, the funnest part of podcast camp, the Pod Wars. All right, that about wraps it up. Until next time, take it easy.